Hi everyone. So today we'll be talking about breast cancer therapeutics. Breast cancer is the most common type of cancer that affects over 3 million women today in the United States. The median age of diagnosis is around 62 years old. There's an estimated 246,660 new cases in 2016, with an estimated 40,450 deaths in 2016. Breast cancer is now the fourth leading cause of cancer death, and the median age of death is around 68 years old. Before we go into the treatment options for breast cancer, it's important to understand that there are various types of breast cancer. First of all, breast cancer could present with hormone receptor positive or hormone receptor negative. This is also referred to as estrogen receptor positive or estrogen receptor negative. Plus, the breast cancer could show human epidermal growth factor, also known as HER, and this could be positive or negative. If a breast cancer is hormone receptor positive, a patient with this type of breast cancer always requires endocrine therapy. Chemotherapy is dependent on whether they are HER positive as well or have a high rate of reoccurrence depending on the Oncotype DX test. The Oncotype DX test is a genomic test that analyzes activity of 21 genes that can influence how likely a tumor is to grow and respond to treatment. This is scored from a range of 0 to 100. If a score is greater than or equal to 31, a patient is at high risk of reoccurrence, and benefits of chemotherapy are likely greater than the risks of side effects due to chemo. If a breast cancer is hormone receptor negative, no endocrine therapy is required. However, chemotherapy is required along with anti-HER2 regimens such as Herceptin, which we will talk about later. But this is only if a patient is HER positive. If a patient also presents with a HER positive breast cancer, again, as mentioned previously, they should always use anti-HER2 treatments such as Herceptin and chemotherapy. If a patient is hormone receptor positive but HER negative and their Oncotype DX test is greater than 31, then these patients should also consider chemotherapy. Now we will talk about the different stages of breast cancer, starting with stage 1. Stage 1 is the presence of a tumor but with negative lymph node involvement. Stage 2 is where you have a small invasive tumor but there is lymph node involvement. Stage 3 is where you'll have a local significant tumor but there is no evidence of any distant metastases, for instance, spread to other organs. Stage 4 is classified as metastatic breast cancer and there is evidence of distant metastases. Now, when it comes to surgeries can cure most cancers, most especially in women who are stage 1 or 2. There are two types of surgeries. There's breast conserving therapy, also known as BCT, where there is removal of part of the breast. Then there's a mastectomy, which is complete removal of the breast. Women with BRCA1 or BRCA2 mutations, it's actually recommended that they undergo a mastectomy and also removal of their ovaries. BCT is usually given with radiation therapy from approximately 3 to 5 weeks. BCT is actually an appropriate therapy for women who have stage 1 or 2 breast cancer and is preferable as survival rates are equivalent to those who get a mastectomy as proven in clinical trials. BCT, however, is contraindicated in those who have lupus, mostly due to the radiation. If a woman had a mastectomy and had greater than 4 positive lymph nodes, they must undergo radiation after their mastectomy. Now, ideally, most clinicians like to give chemotherapy after surgery and then radiation after the chemo. Hormonal therapy is also considered if it is required in a specific type of breast cancer at the end for many years. When it comes to chemotherapy, combination chemotherapy regimens are way more effective than monotherapy. Anthracyclines such as doxorubicin or epirubicin and taxanes such as docetaxel or paclitaxel are commonly used in modern chemo today. From clinical trials, incorporating a taxane actually reduced risk of distant reoccurrence, any reoccurrence, and overall mortality compared to a non-taxane regimen. This was mostly tested in patients who were HER positive. Now, chemotherapy can be given anywhere from 12 to 24 weeks, but it should be started within 12 weeks of surgical removal. In clinical trials, there has been a higher disease-free survival and overall survival when patients receive chemo every 2 weeks versus every 3 weeks. But as you can imagine, there are more severe toxicities associated with every 2 weeks compared to every 3 weeks. Also, another interesting fact is that women who have triple negative breast cancer, which is hormone receptor negative and also HER2 negative, actually showed great benefit with weekly paclitaxel compared to every 3 weeks. One thing that is commonly seen with patients on chemotherapy is chemotherapy-induced nausea. So antiemetics are definitely very important when it comes to supportive care with oncology patients. Some drugs that are used for chemotherapy-induced nausea include Zofran, dexamethasone, and aprepitant. Some common side effects seen with chemotherapy is loss of hair, weight gain, fatigue, and DVT, most especially with combination regimens. When it comes to taxanes, you will see peripheral neuropathy, myalgias, and hypersensitivity reactions. With anthracyclines, there's a risk of cardiomyopathy. Here's an example of a chemotherapy regimen called TAC, which includes docetaxel 75 milligrams per meter squared IV on day 1, doxorubicin 50 milligrams per meter squared IV bolus day 1, and cyclophosphamide 500 milligrams per meter squared IV day 1. However, the doxorubicin should be given prior to the cyclophosphamide. This cycle would be repeated every 21 days for a total of 6 cycles. There are plenty different chemotherapy regimens out there, but not to make this video too long, I'm just giving an example of one. Biologic agents are really important when it comes to adjuvant therapy for breast cancer treatment. One particular one that's very important is called trastuzumab. Trastuzumab is a mouse protein antibody that targets HER2 receptor protein specifically. So it's a monoclonal antibody. Now, since it is a mouse protein, people will experience reactions from this. The body will react. However, what's really awesome about trastuzumab is that it shows significant survival benefits when given with chemo in women who have HER2 positive breast cancer. It can be given in combination with chemo or it could be sequentially after. Some ADRs that have been associated with trastuzumab is cardiac toxicity, which is less with sequential therapy, and infusion reactions. Also, side note, trastuzumab is also known as Herceptin, which is its brand name. Now, women who have triple negative breast cancer have paclitaxel with trastuzumab for a total of 12 weeks, and then afterwards, trastuzumab every 3 weeks for a year. And now we will get into the endocrine therapies. There are several different types of endocrine therapies as listed, which include tamoxifen, removal of ovaries, ovarian irradiation, luteinizing hormone-releasing hormone agonists, also known as LHRH agonists, and aromatase inhibitors, which are commonly referred to as AIs. Endocrine therapy differs between premenopausal women and postmenopausal women. First off, we will start out with premenopausal women. In premenopausal women, tamoxifen is the endocrine therapy of choice. How it works is that it's an anti-estrogenic in the breast, but estrogenic in other tissues and organs. If chemo or radiation is not required, endocrine therapy is started shortly after surgery. However, if chemo is required, endocrine therapy should be given after chemo. Usually tamoxifen is given for 5 years, but according to the Atlas trial, patients were tested with tamoxifen for a total of 10 years who were estrogen receptor positive, and what they showed was actually improved disease-free survival and overall survival compared to 5 years. However, there was more associated toxicities, including a risk of endometrial cancer and pulmonary embolisms. So patients could be on tamoxifen for 10 years if they have a high risk of reoccurrence. Also, LHRH agonists such as gosfrelin provide added benefit in combination with tamoxifen. However, you will see more menopausal symptoms when an LHRH agonist is added, such as hot flashes or vaginal dryness. Some ADRs associated with tamoxifen include hot flashes, tension, nausea, diarrhea, and an irregular menstrual cycle. Also, as a side note, it's important to note that there is a risk of stroke, deep vein thrombosis, and pulmonary embolisms with tamoxifen in women who are older than 50 years old. Now, with postmenopausal women, aromatase inhibitors are the standard of care, also known as AIs. Some AIs include anastrozole, letrozole, or exemestane, and are usually given for 5 years. All these AIs actually show similar toxicity and efficacy, and no trials out there have shown one to be superior than the other yet. Some ADRs that are associated with AIs include bone loss, osteoporosis, hot flashes, vaginal dryness, and diarrhea. So, because of the risk of osteoporosis or also bone loss, bone modifying agents are very important in women who are on AIs. So, some bone modifying agents would include alendronate, for instance. So, as a quick summary, it is important to know the type of breast cancer each individual patient presents with, and that will help guide treatment. Also, the stage. So it's important to know if a woman is hormone receptor positive, for instance, because then for sure she's a candidate for endocrine therapy. It's also good to know if a woman is HER2 positive, because then one will need to consider anti-HER2 therapy, such as Herceptin. Also, if a woman is negative for estrogen and also negative for HER2, then chemotherapy is the only option, and it's important to provide optimum chemotherapy for such a patient. Surgery is mandatory in all patients to remove a tumor, and followed by chemo, radiation if necessary, and endocrine therapy if necessary. One important thing to note with stage 4 metastatic breast cancer is that if a woman is estrogen receptor positive, endocrine therapy is the treatment of choice regardless of her status. And there's actually a new drug that was approved called Ibrance, also known as palbociclib, and this actually showed to nearly double disease-free survival, which is amazing. And this worked well with letrozole and also fulvestrant. Now, one thing to keep note is that with stage 4, it's actually incurable, and palliation is actually the desired outcome for any woman with stage 4 breast cancer. Women who have prior stages, such as stages 1 to 3, the optimum goal is to cure the cancer. And that concludes my breast cancer therapeutics video. Please give this video a thumbs up if you liked it and you would love to see more videos like this. And feel free to leave any comments or suggestions down below. And definitely subscribe to my channel if you'd love to see more videos. Thank you.